All right, let's start the last session with Jason Katz. He's going to be talking about the role of ECMO in septic shock. He is advanced heart failure and transplant cardiologist, associate professor of medicine, director of the Cardiovascular critical care, and co-director of the cardiac ICU and mechanical circulatory support program at Duke University.
Thanks. Ugh. I'm really regretting the decision not to wear my glasses because they made me look old. So I'll do my best here. It is a pleasure and a privilege to be back here in Houston. I love this symposium. This is the place where I grew up, and also the home of the world champion Houston Astros. That always is a winning statement here. I have nothing to disclose relevant to the contents of this discussion. I appreciate being invited by Marwin again this year. Actually, in the inaugural Houston Shock Symposium, I was given sort of a softball, an easy one. I was asked in 7 minutes or so to discuss the cardiogenic shock guidelines, and in a single slide I said, heck, there are no cardiogenic shock guidelines, and I was pretty much done. 2023, I've been asked to discuss the rigorous and supportive data behind VA ECMO and septic shock, and I thought, simple in 7 minutes. There's really none, is there? But listen, I got 6 minutes and 2 seconds or 5 more minutes left, so let's try to do this. Let's delve into some of the data. You've seen this before. It's helpful to follow other septic shock talks because I can kind of skim through a lot of this. You've heard the definition of sepsis and septic shock. There are some pathologic and pathophysiologic hallmarks of septic shock. They're included in this great figure by Derek Angus and colleagues, and they include abnormalities in the coagulation pathways, enhanced platelet aggregation, neutrophil depletion, systemic vasodilation, and enhanced permeability, reduced rheolytic properties of the red blood cells, capillary leak, tissue hyperperfusion, and then metabolic dysfunction and tissue hypoxia that ultimately leads to organ system dysfunction, multi-system organ dysfunction, and ultimately patient death. A little epidemiologic data, and I think this is important as we think about the use of mechanical circulatory support, and in particular ECMO for septic shock patients. There are about 48.9 million cases of septic shock per year, causing about 11 million deaths per year, or about 19.7% of all global deaths. And the mortality for severe sepsis or septic shock still ranges on the order of about 35 to 50%. This graphic, though, is important. I want you to remember this for the remainder of the talk. There's really a bimodal age distribution. We're talking about the prevalence of septic shock. It's particularly high in the late neonatal period. That's not who we're talking about managing with VA ECMO here. Who we're talking about for the purposes of this conference are this higher incidence of patients later in life, really peaking at about 75 to 85 years old. So let's get hypothetical a little bit here. Why would using VA ECMO make sense? Why might it not make sense? Well, in its classic form, septic shock is really a vasodilatory condition, and it's usually associated with a hyperdynamic cardiac response and supernormal, if you will, cardiac output. ECMO doesn't improve vascular tone. It doesn't enhance endothelial function. It doesn't improve vascular permeability. And septic shock in its classic form isn't a problem of impaired oxygen delivery, but rather impaired oxygen utilization and metabolism. ECMO cannulas also can be sources of infection, and when you're trying to resolve the patient's bacteremia, which is oftentimes the most common cause of septic shock in our hospitals, you can be dealing with issues of source control for quite some time. And it's also a coagulation nightmare. Bleeding and thrombosis are hallmarks of the septic shock pathophysiologic state and challenges with ECMO. Why, on the other hand, might it make sense? Well, maybe the cardiac function may be hyperdynamic, but maybe it could still benefit from enhancement of systemic blood flow. Maybe VA ECMO will be useful in that subset of patients, and you've heard this already, who have concomitant cardiac dysfunction or septic cardiomyopathy as a part of their multi-system organ dysfunction profile. Maybe cardiac ischemia, if it's present, can be attenuated with ECMO. Maybe it can buy the physician a little bit more time just so that the more validated treatments can take effect, like antimicrobial therapy. And maybe adults are really just big kids after all, because there seems to be a more compelling case, at least still with largely observational data, in ECMO in pediatric septic shock, in which survival with ECMO seems to range in these observational series between 50 and 75%, and the inclusion of ECMO is seen within some of the pediatric septic shock guidelines. It is not, however, evident in the Surviving Sepsis Campaign guidelines. So when looking for ECMO as a tool to use in patients with septic shock, you're not going to find it listed, nor any MCS devices within the Surviving Sepsis Campaign guidelines. It hasn't stopped us from introducing the use of VA ECMO for cardiogenic shock and for septic shock conditions. And this is just one example of many that shows a really rapid increase in the utilization of VA ECMO, in this case for all different types of shock states, even in the absence of really rigorous, particularly prospective, and most certainly randomized clinical trial data. I think what is obvious from the literature that I've reviewed, which is again largely observational, is where we really have limited efficacy with ECMO and septic shock. And that seems to be in the patients that have undergone CPR. Their mortality is abysmal, and particularly abysmal with the application of VA ECMO. In older age, and I'll remind you of that bimodal distribution. So if we're talking about where we're seeing these patients with septic shock, it is in this older cohort of patients who are less likely to benefit from ECMO. And it turns out if you're a rat or a pig, you don't do too well with ECMO either. But there is this population of patients that have myocardial dysfunction in the setting of septic shock, or those with so-called septic cardiomyopathy. And there is, again, observational data from systematic reviews and meta-analysis, as well as multi-center cohort studies and small observational series from single centers, which may suggest a benefit in those that have cardiac dysfunction as a concomitant part of their septic shock pathophysiology. This is one study of 5 academic centers. Again, only 82 ECMO patients compared with 130 controls from large databases. All patients in this case with some degree of at least what they described as severe cardiac dysfunction. And there seemed to be, after propensity score weighting, an association with improved survival with VA ECMO in those that had more robust or more profound cardiac dysfunction. You've seen this already. I'm not going to go through this again, but here's sort of the many pathways that seem to lead to and contribute to the progression of underlying myocardial dysfunction and sepsis. It's not uncommon in the septic shock patient, and when present is associated with marked mortality. Again, this is another study looking at a number of different small, largely observational series of patients that then stratified patients based on presenting ejection fraction. And you get a sense here, at least nominally so, maybe not from a statistically significant perspective, but that those that had the greatest reduction in their ejection fraction seemed to benefit more substantially from the use of VA ECMO. But again, none of these were prospective or randomized studies. Important to remember that. And even if you look at septic cardiomyopathy or myocardial dysfunction through biomarkers, perhaps that's one way we might be able to identify patients who could benefit from enhancement of systemic perfusion through extracorporeal membrane oxygenation. This looking particularly at troponin I as a biomarker of myocardial injury. So in conclusion, the use of VA ECMO for management of septic shock is most certainly controversial and seems to be associated with high mortality and certainly with high resource consumption. The outcomes remain quite poor. Age, like in just about every clinical condition that we deal with in this room, is linked with survival. The greater the age, the worse the outcomes. Perhaps, if you're going to try to identify a population of patients to particularly study who may have a benefit with ECMO, it may be in those septic shock patients that have some degree of cardiac dysfunction, but it clearly needs to be studied and validated prospectively. And I will add, we talk all the time in cardiogenic shock about what are important metrics, what are the important targets. Well, don't even get me started on how we should be monitoring, titrating, and managing ECMO in the circuit and support in patients with septic shock. That will be a real challenge. Thank you for your time.
Well, Jason, you took on a very difficult topic. Nice job. Perhaps our panel, particularly those who've had some experience using ECMO in septic patients, can contribute.
Yeah, great talk and great summary. I'm sorry, my voice is a little bit down here. But what COVID has taught us over the last 5 years is that what you're absolutely right, that patients who have VA ECMO with severe sepsis and septic shock, the outcomes are dismal. But we all in this room have taken care of that one patient or two patients who actually we placed on a circuit, changed to VAV, and then switch to VV, discharge patient home, and doing very well. So there, I think this is an opportunity for all of us in the room to venture into this arena, because there is a role. As you know, the VA ECMO in these septic shock patients will be short-lived because the myocardium will recover after you treat the sepsis with antibiotics. So I think it's a great opportunity for us to explore this in septic shock patients especially.
I think those are all great points. And I think the value of this observational type data, which is limited, but gives us a sense of how it's being used, areas or types of patient profiles where there may be a hint of benefit, that should help us sort of fuel the fire that these sort of questions that we see, these anecdotal reports bring up in us, and identify patient populations in whom there are opportunities to study patients prospectively. If you were going to ask me, it would be in young patients that have some evidence of contractile dysfunction or a mixed shock picture at the very least. I didn't show you more recent data from just this year in ASIO, just recently in one of the ASIO journals, that really compared the use of VA ECMO in patients with pure cardiogenic shock, pure septic shock, and mixed shock. Those patients that had clearly cardiogenic shock with a component of systemic vasodilatation. And while the mixed shock patients didn't have as good outcomes as the pure cardiogenic shock patients, they were considerably better, again, in an observational fashion, than the pure septic shock patients, and particularly those that were of younger age. So I think, if we're going to focus and be prospective and be rigorous about designing a trial around these patients, that would be the population that I would suggest.
I think that this is one of the most difficult situations that you faced when you are on call and you get the call for the possible VA ECMO. And when you review, everything looks like sepsis with some cardiac involvement. In our experience, we always have the question if the ECMO is going to help or not the patient. But not only sepsis, also all the vasodilatory etiologies, including we have some experience with adrenal crisis, with very low ejection fraction. We say the ECMO is not going to help. Some controversial opinions during the decision-making process. But we have patients that with very profound vasodilatory state with cardiac involvement, they recovered the heart, and we were able to decannulate, and the patients there.
I agree. I think, again, if the review of these observational series, which I'd be lying if I said I was an expert at before this talk, I became learned in the process of preparing this, but what I've identified are patients that I would be more compelled to push my cannulating team to consider and my intensive care unit to take care of. We're challenged enough in other areas within just sort of the cardiogenic shock group patients, particularly those that have cardiac arrest or those that may require eCPR, to sort of tease out the data and who we should be cannulating and who we should not. Then you add sort of the septic shock patients, and you're going to drive every one of my surgeons out of the hospital in a heartbeat. And what I didn't talk about, which again is the big elephant in the room, is you have to talk to administrators and hospital personnel and leaders about how you utilize these resources, how do you utilize these ICU beds, and how you make this at least somewhat cost effective. And the literature around that is, if you think this is interesting, is really fascinating. Stephen.
Jason, literally 30 years ago next month, I was privileged to help describe this disease, the hantavirus pulmonary syndrome. And we started using VA ECMO, but we started as a salvage therapy, and it looked promising enough that we then moved it up more proximal in the treatment algorithm. You got any idea whether these studies, it's hard for me to imagine that VA ECMO is up in the proximal list on these folks with septic shock.
Yeah, and I didn't see much in the literature. I think as much as we all have anecdotal stories of patients being saved on VA ECMO, we can also easily recite our disaster stories of VA ECMO. And if I've recognized one thing over the years, and one thing that I try to tell the trainees, it's the longer you're on one of these devices, the more likely you are to get some complication of these devices, and in many cases quite devastating, and in many cases quite life-threatening. So there's a challenge with the idea of implementing these earlier or upstream that have to be sort of carefully thought out for sure.
The longer you're on, the more likely you are to find out what it means to be in septic shock on ECMO.
Absolutely.
Well, perhaps to summarize, VA ECMO can be a valuable tool in sepsis patients if they're not too old and they have evidence of cardiac dysfunction. And selective application appears to be reasonable in the absence of
That's right. So
randomized
all of us
data.
up here are screwed. Yeah. Thanks.
Our next talk is novel treatments to prevent muscle wasting in shock patients.